Well, thank you, Kim. It's a great pleasure to be here with all of you today. And I've had the privilege of enjoying today's presentations with you. And as I listen, I can't help but reflect on what an incredible era that we're in society today. Some have called it the fourth industrial revolution. So the first industrial revolution was really mechanization, changed society as we know it today. The second was electricity, changed society as it was known. The third began about 50 years ago. It was really the digital age, and it had a slow ramp up, but we all see the incredible impact. The fourth, which is incredibly compelling and arguably is a different era, is really the blending of the physical, the digital, and the biological. And we see evidence of that in all the stories and presentations that we saw today. I'm going to talk a little bit about healthcare and how this incredible combination of technology is influencing healthcare and disease management for the better. So when those of you who know Mayo Clinic, when you think of the Mayo Clinic, you may think of us as a trusted partner and provider of healthcare for complex care, undiagnosed conditions. And that's indeed true. And it's something that we take great pride in, sometimes being a court of last resort and sometimes even able to change the course unexpectedly for the better for our patients. So for 150 years, we've come together in teams of experts around building solutions. But what I'm really excited to share with you today, with this focus on the near future, is Mayo Clinic, the Innovator. What you see on the screen there is one of our nation's most innovative anatomy labs. Yes, that steel container that you see in the middle of the screen contains a cadaver. What's different about this anatomy lab is that as the medical students dissect this cadaver, they are simultaneously looking at those screens, seeing digital images of their exact cadaver, so that by the time they finish the course, they have seen MRs, CTs, ultrasounds, and plain films of that actual person. And they begin to connect the dots in a way that has never been done before. So, for Mayo Clinic, there are actually so many exciting things going on that I have to kind of constrain myself and figure out how to squeeze this into 10 or 15 minutes of your time. One area to talk about is genomics. You talk about big data. Our DNA contains 3.2 billion base pairs. Just to give you a sense for that, if we were to type that out in 12 font on paper, single-spaced, and start stacking those pieces of paper up, you would have a stack of papers taller than the Statue of Liberty. It initially took our nation, through the NIH and others in the Human Genome Project, 13 years and $3 billion to sequence the first human genome. Today, it can be done for just over $1,000 and in just over 1 day's time. And we expect it to soon be available even more quickly than a day and at the cost basis of $1,000 or less. It's incredibly powerful. Yet, how many of you have had genomics impact your personal care or your interactions with your doctors? Show of hands, how many of you have had genomics? See, I don't see any hands going up. So there's a tremendous gap, well, maybe one here, which is excellent. There's a tremendous gap between what is known scientifically about the genome and what's actually happening in patient care. And that's an area that we at Mayo are focused very intently on. So I had my genome sequenced, and I didn't have any specific concerns. I did it as sort of a personal experiment to see what's it like, what do you learn? When my genome was sequenced, what I found was incredible. So there's a whole field called pharmacogenomics, but I now know that if I need a blood thinner called warfarin, I will metabolize it very slowly. And if I were to be started on a normal dose of Coumadin or warfarin, I would likely be at risk for a bleed episode that could be catastrophic. Think about that. Now I know this, so if I need a blood thinner, hopefully I won't, I can approach my physician, we can look at the data together, and we can start at the correct or much closer to the correct dosage. I also found out that I am a carrier of cystic fibrosis. I'm a recessive carrier. Now I have 3 teenage kids, and they're all doing fine, but I can now counsel them that when time comes, should they decide to have children, they may be carrying the gene, and they, unlike me, can know that ahead of time and can choose to have their spouse or loved one tested before they choose to have kids. So think of the power of genomics. What about rare diagnostic conditions? So at Mayo Clinic, we've launched a diagnostic odyssey or diagnostic uncertainty clinic, and we found incredible results. And I'm going to tell you the story of this young man, Dustin Lynch. Dustin, as you'll see in a moment, had suffered for his entire life from a debilitating movement disorder. He'd been to countless medical centers, never able to find a diagnosis. He came to us at Mayo Clinic, and as part of his workup, we sequenced his entire genome, and we found something significant. But let me share his story with you now.
We adopted Dustin. We got him at 3 months old. When he was about 18 months old, I took him out of the high chair and stood him on the floor, and he kept going sideways and couldn't keep his balance. It was sort of unusual. Things started getting worse as he started getting older. He started having more and more of the jerking like he does. And I've worked 23 years trying to do whatever we have to do to hopefully make Dustin's life as happy as he can be.
So we sequenced his genome. We found a rare hereditary ataxia of which there have been 100 known cases in the world reported in the literature. We weren't able to change his genetic makeup, but we were able to give him the correct diagnosis for the first time in his life and have a team of neurologists design a special treatment for him that has made a huge difference in his life, as I think this next video will show. Before this, Dustin was unable to feed himself and could barely clothe himself, as you could see. This is him after treatment. So after treatment, Dustin's playing baseball and living a virtually normal life, and that is the power of genomics, bringing a rare condition to light and allowing our team to focus on it and allowing Dustin's odyssey of endless testing, sometimes painful and expensive, to end and focus on living his life. That's the power of genomics. Thank you. Our vision is that genomics will influence the medical care across the entire spectrum, that if you need a high blood pressure medicine or a statin, that we will have genomic analyses done first so that you can know in advance whether it's going to work or not. Difficult cancers, unresponsive to chemo, we think a new era is upon us where we'll be able to identify the genetic abnormality of a cancer, find which chemotherapies or even immunotherapies, far less invasive, work, and focus the treatment on what works instead of the old system of trial and error. The next area, robotics. We've heard a lot about robotics today. It's fantastic. Well, what if we could bring robotics not only to the operating room, which has been done, right? So you're familiar with these incredibly sophisticated machines that we now use in operating rooms that allow us to do minimally invasive and rapid surgery. But this is a different story. This is a story of a collaboration between the University of Pisa, the Mayo Clinic, and bioengineers at Arizona State University, who took what was being designed as a robot to package boxes using biomimicry. So the engineers in Pisa were engineering a human hand. And then they said, what if we could use that for amputees? And the result is a technology they call soft hand, and it uses technology that is intuitive, and when you decide you want to grab something, it senses, your mind, of course, through your nerves, activates the correct muscles. This senses these incredibly subtle electrical signals and tells the hand what to do. Now watch this video. And notice he's an amputee just above the wrist. Most amputees stop using prostheses because they're ugly, clunky, and even scary. They scare kids. And so this is a whole new opportunity in robotics, and that is a robotic hand. And this gentleman who suffered a right hand amputation can now handle medium-sized objects. He can now move chairs and tables. And he can even hold a pen and write for the first time with his right hand again that had been lost. So that's where we're going with robotics. We think it's incredibly powerful for these folks. All right, let's shift gears again. Another new technology, and this one's not even the near future. This is available today. So in our country, 49,000 people die every year of colon cancer. Yet, unfortunately, about a third of those of us that should be screened don't get the screening. And I can't imagine why. I mean, I've had a colonoscopy, and it was just great, right? So you know, who isn't in a hurry to line up and get screened for colon cancer? Well, about 10 years ago, one of our gastroenterologists began asking the question, what if there's a better way to do this? What if we could identify tiny amounts of shed tumor DNA and even polyp DNA in the stool? And long story short, after extensive clinical trials, we have launched we've licensed to a startup the test called Cologuard. So Cologuard is an alternative to colonoscopy for colon cancer screening. And it isn't for everybody. It's for patients with no known colon disease, if you will. But for those patients, which is the majority, this can be done with a simple stool test sent to your own home. And it not only screens for colon cancer, in many cases as well as a colonoscopy, it also screens for rare cancers of the bile duct and liver that also shed DNA that heretofore there has been no screening available for at all. So to us, this is the power of innovation, creating a solution that patients like. By the way, though, if you're ever interested in this, you have to ask your doctor or your provider to prescribe it, and then it gets sent to your home. But it is less invasive, safer, in certain regards, more thorough than a colonoscopy, and it's about a quarter of the price. So we talk a lot about costs of healthcare. We get into healthcare policy decisions. We shouldn't be arguing about how do we lower the price of colonoscopy by a few $100s when it's a $2,000 to $3,000 procedure. We should be figuring out better ways to do it, and that's what this represents to me. And then we also hear a lot these days about 3D printing. How is it impacting patient care? Well, I want to show you, some of you have noticed this blob up here and wondered, is this a human organ? It is. This is an exact replica of a 24-year-old police officer's liver. This particular person had testicular cancer, which unfortunately metastasized to his liver. Oh, good. You can kind of see this on the screen. But the pink balls inside his liver are the metastases. This represents the vast majority of his liver. But you can see this side, the smaller part of the liver, is not affected. These tumors had to go to save his life. But it was such a complicated surgery that the team wasn't sure they could do it effectively. By printing this and studying it, the team rehearsed the surgery multiple times, and in an all-day-long surgery with multiple team members, they were able to resect all of the tumors in this young man's liver, and he's now back on the beat, healthy and cancer-free. That is the power. Think of 3D printing. So 3D printing. One last story before they give me the hook. Isn't this incredible? Anyone have a guess what this is? This is a human brain, but this is called tractography, and it uses a technique called functional MRI, and this is a pianist. This pianist, unfortunately, has a brain tumor that needs to go, but she loves the piano, and we don't want to hit any of those tracks that activate when she plays the piano. That's what you're seeing right now. So our neurosurgeons come together in our precision neurotherapeutics lab and have figured out how to map the human brain so that when she has her surgery, they are not going to hit the tracks that you cannot physically see. It's all gray matter, but they now know help this patient play the piano. So I'm going to show you this short video. This is an awake patient playing the piano while she has brain surgery. So her tumor's being removed. She's awake. She was asleep while they removed a chunk of her skull. That would hurt. But it turns out that the brain actually has very few sensory neurons. So you can actually operate on the brain with moderate sedative while she plays the piano. But there's one other step that is in the near future, and I'm going to go to the next slide. So we think that surgical instruments have not evolved fast enough to meet with this fourth industrial revolution. And we have a team in Arizona working on smart instruments. And the idea behind it is that after you've done the functional mapping of the brain and you know what's important, I'm going to roll this video clip and imagine that this could be a scalpel, or it could be a laser, or it could be a retractor. But we're going to map this patient's brain with the areas that we need to stay away from during neurosurgery, because again, you can't visually determine this. And when the instrument gets close to it, It's going to alert the surgeon that they're getting close to a critical structure. And that then allows the surgeon to move away and, if possible, work completely around that area. So this is entering the era of smart surgical instruments that takes us a step beyond the robotic surgery that has been so successful. Do we have time for one more? One more story? Okay, you're a kind audience. I'm just going to talk briefly about tissue engineering and regenerative medicine. This is for, in this story, patients who have had massive laryngeal trauma or throat cancer. And we have done an MRI here and then had a computer reconstruction of a patient's larynx or voice box. This is a biocompatible material here, but it's going to not work very well if we put it in someone's new voice box and windpipes. So we're going to first harvest. So we're going to create an exact replica of half of this larynx. We're going to then create this 3D image of it that you see. But we need tissue on this. We want to put the patient's own tissue on it. So what if you could take some of their cells, reprogram those cells in the lab, get them to reproduce, and cover this with the proper mucosal cells? Turns out that our fat is loaded with mesenchymal stem cells that you can re-engineer. So there's your fat, or this patient's fat. It's going to float up out of the Petri dish, and these adult stem cells are going to sink. Those can then go into a lab. And in the lab, we get them to reproduce. With growth hormones and special signals, we can re-engineer them into any tissue that is necessary. We have a program doing cardiac myocytes, cartilage, neurons, and in this case, the mucosa that needs to cover this. Now imagine a patient with a cancer. We've done this 3 weeks prior. It takes about 3 weeks to grow the tissue. We resect their larynx, and instead of spending the rest of their life with a feeding tube and trying to communicate with writing, having a debilitating condition, our intention is to put the engineered tissue combined with the 3D printed back in the human larynx. This is not happening today, but this is a lab at Mayo Clinic in Arizona that is actively pursuing this, and we are hopeful that within the next 3 to 5 years, we'll be able to begin our first human surgeries just like you saw here today. So as I conclude, there's a lot of white noise in healthcare these days, particularly healthcare policy, and those are serious issues that we need to grapple with. But I wouldn't want any of us to forget the incredibly exciting near future in healthcare as all of these technologies mature. Thank you very much. Thank you.
Dr. Decker, I have a few questions for you. I love that the Mayo Clinic is always on the cutting edge with that patient-first healthcare.
Thank you.
But you're really ahead of the curve. What incentives are out there for the rest of the medical community to innovate themselves or adopt innovation? Because I don't know if you know this, but unless there's an actual code to file something under, including new technologies, the physician doesn't get paid for using it.
That's right. So there's whole sets of challenges here, but in summary, it's actually excellent. We believe in partnerships. So we partner with entrepreneurs and private industry. We partner with artificial intelligence groups. That can accelerate innovation. Then to the regulatory environment, we strongly actually encourage bringing that, whatever the government agency is, on board before you have a final product, and talk to them and figure out. So we do this all the time with our clinical trials. When we had an exciting clinical trial for an immunotherapy for melanoma, before we launched it, we got the FDA to come look at it and say, you know what, if this works, we're going to approve it. It worked, and now there's an immunotherapy for metastatic melanoma for the first time ever. So the critical key is partnerships. Yeah.
And it's one thing when I'm advising startups who are in the healthcare community, I always suggest get your pre-sub first, right, with the FDA, and two, go for that code, because it's not going to do you any good. I mean, you might as well have them before you even go into clinicals, right?
Absolutely.
Also, one more question in terms of video conferencing technology that's used for doctors to treat and diagnose and treat patients. they're really ahead of the curve when it comes to policy, because there are still policies in place that don't allow a doctor, let's say, who's in California,
Right.
to use video conferencing technology such as Doctor on Demand to diagnose and treat someone in
right.
Arizona. How do we get ahead of this curve and solve this problem?
Yeah, that is mostly, again, a legislative challenge. And in this era of connectivity, we believe strongly that physicians should have either a single national licensure, which is one solution, or a stepwise approach we've been advocating and begun to create a national syndicate of states that say, you know what, if you're keeping a good eye on your doctors, they can practice telemedicine in our state. And so there's this reciprocity. So we've already begun that. I believe there's about 15 to 20 states that have agreed to reciprocity. So solutions are on the way, and it's something we all have to work for.
Fantastic. Thank you so
Thank
much.
you very much.
Dr. Wyatt W with the Mayo Clinic.
Thank you.